So we're going to finish up the central nervous system today, go over the spinal cord, the impulses of the spinal cord, and the overall general structure of it, and then we'll start into the peripheral nervous system. So we will be having the exam next Thursday. So Wednesday should be a free day. Again, if you want to come in here, study, be here the whole time. As I stated yesterday, though, if no one's here at 8:15, this isn't you having a nice leisurely start to the day. So if you want to study and have questions, then you need to make sure that you're here on Thursday or Wednesday. I probably will be doing the exam in the next classroom, just because I like to set up a little bit better, it separates you guys, remove a little temptation. And Tuesday at the end of the class, or towards the end of the class, we will dissect the brain. So you kind of want to look through that section of your lab manual. There are questions in that part, and should be central nervous system, and then look for the section that it says sheep dissection, sheep brain dissection. You want to look through that. There are some questions. You're not going to have to turn the questions in, but it does kind of help you walk through the actual dissection process. Any other questions? Okay. So remember we talked about that spinal cord being in the middle of the vertebral column. So if the red is the vertebral column, we have the structure a little under an inch in diameter that goes down, ends about L1. Okay? And those spinal nerves, again, exit out at the level, the appropriate level of the vertebral column. And we'll spend some time, more than likely on Monday, talking about those. Because you are going to have to know some of the spinal nerves specifically that go to some of the primary muscles. All right? We'll probably make you have to go back and do a little review of the muscles and what they do. Okay? Specifically muscles of the forearm, muscles of the, at the forearm, at the arm, muscles of the legs. So when you get here, this is the end, and it's called the conus medullaris. That's the end of the spinal cord. Now, some of these spinal nerves are going to continue to go to their destination. So they're going to emanate, they're going to originate here in the spinal cord. That's why they're called spinal nerves. But they're going to end up having to go all the way down here to their destination. Because of the way they fan out, this is referred to as cona equina, which is the horse's tail. And we had that filum terminale, which was an extension of the spinal cord, covered by the pia mater, that kind of anchored that spinal cord down, so it's not moving extensively in the column itself. And then you also have these little kind of sawtooth-shaped structures, which were, again, extensions of the pia mater that help to anchor to the dura itself. So it doesn't really go all the way out. It actually would extend a little bit more in, but I want to make a point for hyperbole. These are referred to as the denticulate ligaments. Same overall structure, protective mechanism. We have the bones on the outside, we have the dura, we have the arachnoid, we have the pia, so our meninges, and those are all protecting the spinal cord. We talked about the cervical and lumbar enlargements. Those are going to play a big role when we start talking more specifically about the specific spinal nerves. We talked about the cervical plexus, the brachial plexus, the lumbar, and the sacral plexus. Now, when we look at a cross-section of the spinal cord, so the top has the vertebra still surrounding it. The bottom, we've obviously removed it. Now, here, so we have the body and the spinous process. Anybody tell from that one what level of the spinal cord that's from?
Cervical.
Why?
It's got the
There's a bifid here, we've got our foramen there. I'll show you why they kind of made a little bit of a mistake from the standpoint. So, when we look at it, we've got this structure here, and this is actually going to be a little bit more better looking from the standpoint, a better descriptor. When we look at it from down here, it's not as good of a descriptor. But we've got these processes here of a dorsal median sulcus, so it's coming in, and we have the ventral median fissure. Sometimes these are referred to as the posterior sulcus and the anterior fissure. Again, potato, potato. Now, what do we know the difference between a sulcus and a fissure? Pardon me? Fissure is deeper. If I look at this one, does this fissure look deeper than the sulcus? No, but if I look up there, it makes it a little bit different. So that's why I said the picture's a little bit better from that standpoint. Now, we had that same organization that we've been talking about. The core, fluid-filled core, surrounded by gray matter, surrounded by white matter. There's my central canal. Remember, that's the thing that's continuous with the fourth ventricle. It goes directly down through the spinal cord. Then we have our gray matter, and then we have our white matter. Okay? The gray matter are cell bodies, the white matter are fibers. Now, if you look at the shape of the gray matter, you can see it kind of both. We have what's referred to as the dorsal horn, and there's the dorsal horn right there. This is where information comes into the spinal cord. Always. And if you notice, we have a ventral horn. The ventral horn is where motor impulses come out. So when we talk about things, again, if I raise my right hand, that impulse again is going to be starting over here on the left side of my brain. It's going to decussate, cross over at the medulla oblongata, in the pyramids, and then it's going to go down the spinal cord, and it will go out the ventral horn to the appropriate spinal nerve. And that spinal nerve will then go to the appropriate muscle, so that you would have flexion of the forearm. Okay? Now, I've got them on both sides, obviously, because I have muscles on both sides. They're identical. Now, there is an area right in here that's referred to as the gray commissure. What do we know about the term commissure, or commissural fibers? They cross over. So this allows for impulses, and we're going to talk about that today, to cross over from one side to the other. Okay? Because again, some impulses will do that. They don't cross over up at the top, they cross over at a different point. But almost all things, as it starts to ascend up into this, to the brain, will cross over at that. When we look at this process, there's another horn up there, and this is the reason I said they kind of made a little bit of a mistake. And it's called the lateral horn. So you can see it here, you can also see it up there. The lateral horn really is only in the thoracic. So if you go back to your first term, AMP1, when we went over the autonomic nervous system, we had sympathetic and we had parasympathetic. Does anybody remember another name for the parasympathetic? No. It has to do with their location. Craniosacral, because that's where they originate from. Well, the sympathetic nervous system is also referred to as the thoracolumbar, because that's where they originate from. So the sympathetic nervous system tends to exit out through the lateral horn. So what did we say this was? Cervical. So there really would be no reason for it to have a lateral horn. So a little bit of a mistake from their picture standpoint. And we'll talk a little bit about these when we get into the peripheral nervous system, but these are essentially ventral rootlets that are going to form and form the spinal nerve itself. So those are the spinal nerves that you see at that particular point. Yes, sir?
Was it sympathetic or parasympathetic that exits through the lateral?
Sympathetic. Yes, ma'am.
So did you say the dorsal horn, the posterior dorsal horn?
Sensory information is coming in.
Okay.
we have these things called funiculi. Okay, funiculi is just a fancy way of saying our white matter. And we're going to divide it up into a dorsal, a ventral, and a lateral. So the way I want you to start thinking about this is information that's going to come in. Okay, and I'm going to talk specifically about coming in. So it's ascending, it's afferent. We'll talk about motor afterwards. But this is a process where information is going to be coming in. So let's go back to that analogy of going to the UN. Okay, I'm going to go to this big giant building, and I've got a sign that says what I am. Okay, because I don't speak the language. And I have somebody who reads my sign and says, okay, what I want you to do is I want you to go over to that bank of elevators over there, and you're going to go up to the 34th floor. If another person or another sign comes in that's different, they're going to say, okay, I want you to go to that bank of elevators. So a good way of thinking about our white fibers are elevators, because they're going to be going up and down, and I'm going to send you to a specific area. So depending on whether you're pain, depending on whether you are discriminative touch, whether you're coarse touch, whether you're vibration, you're going to be set on a particular elevator. The elevators are called funiculi. Okay? Now, they do have their location. We still have the commissural because we're going to cross over at certain points, and we do have ascending and descending. So when we look at them, all the blue here, and again, you really only have to look at one side because they're exactly the same. One just is processing one from one side of the body, the other is processing from the other side of the body. So where you see the blue, those are all ascending fibers. Thus, you're carrying information to the brain or to the cerebellum. Whereas the red are descending fibers. They're motor fibers. They're taking information out to the body. Okay? And we're going to be talking about each of these particular ones as we isolate them. Because they're going to have a couple different names.
Is that primarily why the ventral fissure is a fissure, as opposed to like the dorsal sulcus is deeper because it needs?
No, they aren't sure exactly why it's deeper, to be honest with you. But they just know it is, and that's the reason that they gave it its name. So, now, when you go through this process, you're going to have some pictures that I might have actually taken out because I don't find them to be as important. They actually might be on in the peripheral nervous system. So, we're going to talk about the number of elevators you're going to take and where they might go. If you are going to the brain itself, to the cortex, you're going to go on 3 elevators. If you're going to the cerebellum, you're going to go on 2 elevators. And I'm going to name these elevators as first order, second order, and third order neurons. Now, if you have a different textbook, not a different one from Marriott, but if you're looking at a different textbook, these are sometimes referred to as primary, secondary, and tertiary. Okay? But Marriott uses first order neurons, second order neurons, and third order neurons. Now, they have their destination, so to speak, and their origination. So when we talk about a third order neuron, or excuse me, a first order neuron, a first order neuron is basically going to come in from the body, and it's going to go to a thing called a ganglion, a dorsal root ganglion. So that's the structure right here. It's going to come in, and if you go back to the descriptions of neurons, we had unipolar, bipolar, and multipolar. So the definitions of those is a multipolar, which is what most of them are. It all has to do with how many things are coming into the cell body. That being the axon. So does it have more than one? Yep. Does it have more than 2? Yep. So this would be considered multipolar. If I have one that looks like this, how many are going into the cell body? 2, so that's bipolar. And then we have one that's not that common. How many go into that one? 1. It's a unipolar. So our dorsal root ganglion is similar to this. So impulses are going to be coming in until they hit that dorsal root ganglion. Okay? And these are referred to as a first order neuron. It's the first elevator that I got on. Now, there's another place that this first order neuron can go to. Instead of stopping at the dorsal root ganglion, it's going to continue on and it's going to go to the brainstem. Those are 2 examples of dorsal root ganglion, or of first order neurons, excuse me.
So, with body to brainstem, does it go body dorsal root ganglion, brainstem?
Nope, just bypass the waves. Hey, how's it going?
Okay.
Keeps moving on. Now, the second one is going to be pretty straightforward because it's going to go from where you ended. So if this was my example here of my first order neuron, I stopped at the dorsal root ganglion. It means that I'm going to then, my second order neuron is going to start here at the dorsal root ganglion, and it's going to go up to the thalamus or the cerebellum. This is a second order neuron. And I will be going over examples of this to drive this point home. Okay? Now, last one's a piece of cake. Okay? It's going to go, so once I get here, we're done. There's no leaving the cerebellum. Okay? These are the proprioceptors. Those receptors that are associated with our skeletal muscles, our joints, our tendons. So again, when I raise my arm up, my body knows I just raised my arm up. I don't have to look and go, oh, okay, arm's up. Just from the standpoint of the receptors that are present in the muscle, they're sending impulses to here. Why? So we can play the Mother May I game. With our information coming down our middle cerebellar pedicles from the primary motor cortex. Hey, can I raise my right arm? Let me know. Let's take a look. I got some information that came up through all of this, through my inferior cerebellar pedicles. Yeah, you can raise your arm. And then cerebellum is going to tell the brain through the superior cerebellar pedicles what to do. Okay? Now, third one, we're going to go from here to the cortex. And that will always be a third order. So if you're going to the cortex, you're going on a third order neuron. And it's always going to go from the thalamus to the cortex. Yes, ma'am.
Can the second order neuron go from the brainstem to the thalamus?
Generally not.
Okay. So it would just go to the dorsal root ganglion.
Yes, sir.
Second order neurons, do they stop at the thalamus ever, or they always continue
They
through?
will always continue. If you're going to the thalamus, you're going to the cortex. You got the golden ticket. You get to go to the penthouse. Okay, so you're getting on the third order neuron and going all the way up. Now, we're going to talk about 3 elevators. Well, let me rephrase that. 3 locations of the elevators. Because remember, The number of elevators are our first order, second order, and third order neurons. So remember, when you came into the building holding your sign, you go over to that one. You go to the one in the back. Okay? And it's based off of the type of information that you're bringing in. So we've got these three that are present here. So when we look at them, we've got, again, our dorsal white columns, which are the posterior. We've got our laterals, and we've got our ventrals. Okay? Now, do not get lost in the fasciculus gracilis and the fasciculus cuneatus. Those are just simply names of the dorsal white columns. Okay? I'm not going to ask those on exams. I do want you to have an idea that these columns, these elevators, are sometimes referred to as funicula. Okay? Because it does come up in different contexts. So, we're going to talk about the first one, which is called the non-specific. Now, the non-specific is also sometimes referred to as the spinothalamic. Now, that actually makes a lot more sense, because spinothalamic is going to tell me where I started and where I'm going. I'm going to start in the spine, or that's where it's going to come in, and I'm going to go to the thalamus. If I go to the thalamus, where am I going? Always. Cortex. Going to the brain. Now, the non-specific has to do with the type of information that's coming in. Okay, so remember, you got a sign. This is me. Where do I go? All right? And that's how this process is going to work. Then what comes in this part? Pain, temperature, coarse touch. What does coarse touch mean? Coarse touch means there's something on my arm, but I don't know where on my arm. I can't do an X marks the spot. Okay? Now, these things are going to come in, and all this is showing you the anterolateral is just the fact of I've got, and this is the part that is confusing to students. When we start using terms, and we're not always consistent with it, but they really mean the same thing. So, ventral is the same as anterior. So anterolateral means that I'm going to form on one of these two. So it's a little strange because this does look like it's a lateral. When we're talking about lateral funiculi, we're talking about these two things specifically, not that. This is considered ventral. But of being ventral, this one tends to be more ventral, more anterior than that one. So that's why it's referred to as the anerolateral. Okay? So let's look at an example of this. This is the spinothalamic, non-specific. And I do think you should know both terms. Because again, the non-specific tells you the types of impulses that are being processed. Spinothalamic is just better description of the location. So here I've got a little flame burning the foot, temperature. Here, I don't know why I'm holding a razor blade, but apparently I've cut myself and I have pain. All right? So, let's follow the process. And I want you to pay, and I'm pretty sure you're going to be able to tell from there, but what you're going to be looking for are things that look like, I'll make sure I draw it the way that they have it, so it's a little bit. Okay, so this is a synapse. This is going from one elevator to another elevator. First order neuron to second order neuron. So when we have this, got some pain, comes in, what do I notice right there? A synapse. This is the first order neuron. Stopped. So even though it didn't stop exactly at the dorsal root ganglion, it's considered the first order neuron. So then I get on the second elevator. I'm then going to move up, and I'm going to the thalamus. And what do you notice up there? A synapse. I'm getting off of the second order neuron, and I'm getting on the third order neuron. And if I get on a third order neuron, where am I going? Always. Cortex, it's the only place. Now, what else is important? Side of the body did this happen on? Left. Where is it being processed?
Right.
Okay? We cross over here. So the spinal thalamic, the non-specific, crosses over at the level of the spinal cord. It doesn't cross over at the decussation.
When you say non-specific, that's just meaning that we can't pinpoint.
It's one of the basic processes that's there. So pain we can process. I know I've cut myself. I've got pain there. But they use the term non-specific more for the coarse touch description, which is, again, I feel something, but I can't exactly. I know it's on my arm. It's not like, oh, an eerie feeling. It's, no, there's something here. I just can't say it's right there.
So with these examples, where do reflexes fit in?
Totally different.
Okay.
Because reflexes actually don't involve the upper part of the central nervous system. So we're notified of it, and we'll spend some time talking about it, but if this was hot, okay, I don't wait until my brain goes, this is hot. It's hot, arms back, so I have a flexion, it's referred to as a withdrawal reflex, and at the same time, there's an impulse that's going up to the brain to say, you just touched something hot, so that it's not like Groundhog Day, where you're like, why is my hand here? Oh, I was reaching for the pen. Oh, why is my hand here? The brain is notified why you're pulling your hand back, but it has absolutely nothing to do with you pulling your hand back.
So is the withdrawal a first order neuron?
It's not even classified as that. Because when we talk about reflexes, we talk about a receptor, an afferent pathway, an integration center, an efferent pathway, and an effector. So completely different, and we will spend time talking about reflexes. Now, if we look at the temperature, again, the temperature is going to be exactly the same thing. We're coming in, first order neuron, there's my synapse, which means I'm getting off an elevator, I'm getting on a second elevator. I'm going to go up, I crossed over at the level of the spinal cord, and I'm going to continue up to the thalamus, and when I get to the thalamus, I'm going to get off that elevator, and I have the golden ticket, I get to go to the penthouse. I'm going to the cerebral cortex, okay? Now, we look at the specific, okay? Now, this is one that is a little bit more confusing simply because of its name. It's actually got two names to it. Specific, again, primarily because of the impulses that are carried on there, but the name that's the longest is called the dorsal column because it's going to be processed in the posterior funiculi, this area back here. And again, you need to know the terms, but I think when you can start taking the terms and putting them in a simpler context. All dorsal white column means, or the dorsal column is, this is the elevator I'm getting on. Oh, you're one of these? Go back there and get on the elevator. Okay? Now, I'll show you where the medial lemniscal comes from. When we get there. So what gets processed on our dorsal? Discriminative touch and vibration. What is discriminative touch? Oh, there was a bug on it. Where does it hurt? Right there. Discriminative touch means I can do the X marks the spot. Okay? Other things that happen to travel there are vibration. Because when you think about it, unless you're in a car that's vibrating and your whole body's vibrating, usually you can pinpoint vibration. Again, that's the discriminative touch component. Now, on these, I'm going to come in. So here's my touch receptor. Our proprioceptors, I'm not going to talk about just yet. We'll talk about them a little bit more in another section. But it's going to come in. Do I see a synapse here at all? No. So this is just going to continue up, and I'm going to get to the brainstem. And then from the brainstem, this is where it's referred to as the medial lemniscal or the medial lemniscus pathway. So that's where you get the long name. One of them is because I went to the dorsal, but when I got up here, they change it, and my second order neurons are then going to be on the medial limits. I don't really care. I mean, I don't know if that really is going to show up. I just want you to understand it as you're reading through it. It just means I'm naming the elevator. That's all it means, okay? And then, from here, do you see a synapse here? Yeah, what does synapse mean? I'm getting on another elevator. So if I was on a first order neuron, pretty long first order neuron, right? So get on the first order neuron, and now I'm on a second order neuron, and that goes up to the thalamus. And do I see a synapse up here? Which means what? Another elevator. How many elevators are there? 3. If I'm on a second order neuron, it means I'm getting on a third order neuron, and I'm going to the cortex. Now, side of the body did the stimulus occur on? Where was it processed? Okay, so here again, I did not cross over at the spinal cord. I crossed over at the medulla. More than likely, at the decussation of the pyramid. And then I went up. Now the last one has a proprioceptor. This is what you're looking at as a muscle spindle, and again, we'll spend some time talking about muscle spindles when we get into reflexes. The information is going to come in, and what do I notice right there? Synapse. Again, I'm going to get off one elevator, I'm going to get on another elevator. So I'm now going to go up. This one is going to go all the way up to the cerebellum. Is there a third order neuron involved in that? Why? Because once you get to the cerebellum, you stop. What else should you notice? Side of the body did this occur on? Side is it processed on? What did we say about the little homunculus for the cerebellum? Ipsilateral or contralateral? So does this picture make sense? What's processed or what I'm feeling on the right side gets processed on the right side in the cerebellum. Ipsilateral. As opposed to generally what occurs here is it's contralateral. Felt it over here, processed on the other side of the brain. Now, the one thing that we haven't quite figured out is, since we know this is ipsilateral, this is one theory. The other theory is it actually does cross over, but at some other point it crosses back over. Not that big of a deal. The take-home message is it's an ipsilateral process. So when we look at it, again, spinocerebellar, great name, don't you think? Spine cerebellum. And it goes with the spinothalamic. Now how about if we talk about the opposite? Impulses are starting in the brain and going down to the body. These are our motor processes. Okay, they're on our descending pathways. Now there's a couple different names for them. We divide them into direct and indirect. Okay? These are sometimes referred to as our pyramidal tracts. Why? Because they come from our pyramidal cells. That were the cells that made up that thin layer of the cortex. The cerebral cortex. The other name for them, playing along with the easy game, corticospinal. Nice easy name because where is it starting? Cortex. Where is it going? Spinal cord. Corticospinal. Again, try not to one of the things that I've told people that have me for AMP1, sometimes I'm going to say things and it's not to think that you're stupid, okay? there are times where you just don't make a connection. Part of being smart is to learn from things in the past. So sometimes if you didn't see that connection, but someone points it out to you, then you go, oh yeah, I remember that connection. I might be able to apply it to other things. I'll give you an example of something that I'm going to hammer home when we get into hematology. Okay, so just to drive this point home. There is a thing called a prothrombin activator. What do you suppose prothrombin activator does? It activates prothrombin. So when people point out the obvious, so the reason I'm saying that is so that when you look at corticospinal, you're not thinking, well, it's going from the spinal cord to the cortex. Which part comes first? Cortico. So when we talk about the spinal thalamic, which part came first? Spinal cord. So again, when you start looking at the words and try and make leaps, try and make intuitive guesses based off of the word that you're looking at, and it's going to help you on exams. So corticospinal, starting in the brain, cortex going down into the spinal cord. Now these are going to go to our anterior horn. Why? That's where information exits out of the spinal cord. Remember, everything that came in through the dorsal horn. Everything that's going out, specifically the skeletal muscle, we're not talking about glands, so we're not going to talk about the lateral horns, but it's going to go out the ventral horn. This is specific movement. Voluntary movement. Okay? Now, if you notice, and these are both direct, so there is a little bit of a confusion from that standpoint, but we're going to start up here, and I'm going to come down, go through my peduncles, go through all of this process here, and I'm going to end up with the medulla oblongata. What happens to, you might not be able to tell, but the purple crosses over at the decussation of the pyramids. And then it's going to go down, and I'm going to synapse here, and then I'm going to exit out to my spinal nerve to go to a specific muscle. Now, instead of using first order neurons, second order neurons, and third order neurons, in the descending fashion, we use upper motor neurons and lower motor neurons. Everything before the ventral horn is called an upper motor neuron. Anything after the ventral horn, that which exits out and goes to the muscle, is called a lower motor neuron. Now, remember we talked about things crossing over at the medulla, the decussation of the pyramids. But again, if we look at our, this is still direct. They've got this one here that's coming down. I just passed the medulla. Have I crossed over? No. Coming all the way down, and I get here and I cross over at the level of the spinal cord. It's about 15%. So it's perfectly fine with me if you want to just memorize that direct pathways, the pyramidal tracts, the corticospinal, cross over at the level of the medulla, at the decussation. Because this is a smaller percentage, a much smaller percentage. So it makes it easier to memorize. It's not a big deal that the laterals are a little bit different than the ventral. Now we have the indirect pathway. The indirect pathway is anything that's going down that did not go down the direct pathway. Very straightforward. Okay, another term that you're going to hear is, since the direct pathway is sometimes referred to as the pyramidal pathway, so extrapyramidal. Those of you who might take care of patients, especially taking care of patients that tend to be elderly. It's not uncommon for sick elderly people when they go into the hospital, they're removed from their environment. And in the evening, they tend to get very confused. It's actually referred to as sundowner syndrome, okay? And one of the medications that we have used in the past to treat them as a medication, this is Jeopardy, it's called Haldol. And Haldol causes increased extrapyramidal effects. So it's more gross neck, head movement, that type of thing. But it has to do with all of these things. So our balance, course movement again, meaning that it's not discriminative, you're not picking things up, it's more of a gesticulation. Head and neck, eye, all of that process is considered extra pyramidal or the indirect pathway. Now, when we look at that, you're going to see all of these red. Remember, red is the descending pathway. And probably the most important thing that you should be familiar with, again, are the corticospinal tracts, the pyramidal tracts. This one and this one. Those are our direct pathways. Everything else, rubrospinal, reticulospinal, vestibulospinal, tectospinal, they're all just different descending elevators that are part of the indirect system. I will not ask you about them specifically, but you should have an idea about where our corticospinals are. The rest of the red is all indirect. Any questions? So that's the central nervous system. Okay? So again, when you look in your textbook is going to be set up in an outline form, as is my lecture. So you want to talk about the overall idea of the central nervous system, brain, and spinal cord. When you start talking about the brain, you want to start talking about the organization, which I've talked about ad nauseum. Fluid-filled core surrounded by gray matter, surrounded by white matter. In two other areas, it's surrounded by gray matter, which is the cerebral cortex and the cerebellar cortex. We talked about the overall structure of the fluid filled, so our ventricles. We talked about the cortex, what it's made up of. We talked about the white matter. We talked about the nuclei, the basal nuclei that are present there. We've talked about the diencephalon. We've talked about the brainstem. We talked about the cortex, or the spinal cord, excuse me. We talked about how they're all protected. And then we talked about the pathways of impulses going up and down. And so if you think about that organization and try and study in that manner, it's going to help you a lot. Okay? I will, again, if we have time next week, which we should, that's when I'm going to cover all the pathology. Because pathology will always be the thing I kind of leave off if I don't have enough time. The other reason I wanted to kind of have the exam on Thursday is because if we didn't have it on Thursday, since the following Monday is going to be the 4th of July, which we don't have one, and we're going to have that kind of fake assignment thing on Tuesday, so that you don't have to come in from watching the fireworks and vibing a little too much, since half the class probably wouldn't be here anyway. And then we wouldn't be having the exam until Wednesday. So since I'm kind of with the schedule, and this way you also are able to go into your 4th of July weekend without having to think about studying for an exam. Because there's nothing worse than having a holiday weekend going, have a paper that's due on Monday, I have, a test, and you don't really get to enjoy the holiday too much. So, all right, so let's go ahead and take a break. When you come back, we'll start into the peripheral nervous system. And I will try not to overwhelm you too much with the information. Please use the weekend, though, to keep up on the material so far that's been presented. Because there's going to be more material next week, and that's going to be, you're not going to have a huge amount of time to assimilate it into your noggin. So, okay, got 10 minutes. Class, the organization. So again, we've highlighted, we've got that central nervous system that controls everything, but if we don't have a peripheral nervous system, there's no way to connect that central nervous system with the body and with the outside world. Wouldn't be able to understand what we were seeing. We wouldn't be able, you would not be anything, okay? So what we're going to be doing in this particular chapter is essentially this, okay? This is a sensory component, because we've already covered all of this in A&P 1. And we're going to add reflexes and stuff into this process. Now, we will talk about the peripheral nervous system of how the information gets to the somatic, the skeletal muscles, but we're not going to be talking about exactly how you have contraction of the muscle, because again, that was covered in ANP1. So, when we talk about the peripheral nervous system, we need to have receptors. Because again, things are going to be coming inward. That's this whole process. So there has to be specific receptors that have a task. Now, when we classify, let me take it back up, because I want to make sure I drill this point home. There is a lock and key process in all of this. In other words, for each receptor, there's a specific type of stimuli. And you have to have them match up. I do not take my earbud from my phone and stick it on my tongue to listen to music. Why? The receptors for sound are not located there. I don't take a piece of steak and rub it on my eyeball. Why? Because there are no taste buds in my eyeball. So there has to be the appropriate stimuli with the receptor. That's how it works. Okay? If for some reason you have a process and you don't have any type of activation of the receptor, more than likely it means that you either don't have enough stimuli or that stimuli isn't specific to that receptor. Now, we're going to talk about this kind of throughout. Okay? When we talk about how information is going to come into the central nervous system, we have sensation and we have perception. So I'll give you the example that your book uses, which I think is a really good example. If you have a rock in your shoe, and when you step down, you have a sensation that there's something there. Perception is knowing what is there. Okay? Sensation is simply, I'm aware of it. Perception is knowing what it is. And you don't have perception until it gets here. So we're going to go in through, whether it's our visual cortex, whether it's our auditory cortex, the gustatory cortex, whether it's pain and it's going to get processed on the primary somatosensory cortex. It's not until it gets to the association areas that we have perception. Sensation is aware of it. Perception is knowing what it is. Okay? Now, we're going to classify our receptors in different ways. So if I was to divide you guys into groups, it doesn't change who you are, but if I decided to say, I'm going to have all the females on one side, all the males on the other. Okay? Now let's say that right after that I say, okay, I want to have all of the brown-haired people here, red-headed people over here, blonde people in the back. Does it change who you are as a person? No. It just changes how I'm classifying you. So with all these receptors we're going to talk about, I can classify them based off of the stimulus type, the location, and their complexity. And that's what we're going to kind of look at from this process. When we do it by stimulus type, what turns it on? Okay? So we have mechanoreceptors. Mechanoreceptors are based off of when I change the shape of the receptor. I deform it, I bend it in some fashion. And that's how things like touch, vibration, stretching, that's how we were able to detect them, by mechanoreceptors. We have thermoreceptors, which tell the difference in temperature. Now, we have cold receptors and we have warm receptors. They're not quite sure why. Cold receptors tend to outnumber warm receptors by about 10 to 1. It's a lot more than cold receptors. And not that it'll come up on an exam, but I'll add to this in just a second. So, just trying to remember if I want to write this in Celsius or Fahrenheit. there's some overlapping, and if I would have done this correctly, there's some overlapping in the process. So you have an area that's about 77 to about 95. It's considered a comfortable area because, and again, don't get lost in this. I'm not going to ever ask you to repeat these. I'm trying to make a point. I don't think I'm doing that stellar job at it, to be honest with you. There's an overlap between cold and warm where they're both active. So anytime I go below it is when we start feeling cold, cold, cold. And anytime I go above it is when we start feeling hot, hot, hot. And when I get to things like 116 and basically 0, 32, we're going to stay in our Fahrenheit, this is where we have pain. The boxes are pain. So again, all I really want to tell you or drive the point home is that we've got receptors for cold, receptors for warm. They do overlap in this region right here. That's our comfortable region. When I'm at the lower end of our cold, we feel pain. When I'm at the higher end of our hot, we feel pain. Okay? Now, second one, photoreceptors. There's only one place that we have photoreceptors, in our eyeball. The posterior wall of the eyeball. Okay? Again, that's the reason why I can't take steak and put it on my eyeball. There's no receptors there for taste. Now, photoreceptors can be activated by mechanical. So if I was to take my thumb and stick it on my eye and push my eye back, I'm going to see white because the pressure, the different humors that are in there, we have the vitreous humor and the aqueous humor, are going to be pushing down on the photoreceptors and essentially activating them. Is that the purpose of it? No. We have photons that come in. When the photons come in, that's actually what's triggering the photoreceptors. We have chemoreceptors. Basically, exactly like it sounds. They respond to chemicals. Oxygen, carbon dioxide, sodium, calcium. Special receptors that are going to bind to a chemical, a molecule of something, and be activated. Now the last one is called a nociceptor. These are pain receptors. So this is what I was getting at here. When we're too low, our cold receptors aren't being activated. It's the pain receptors that are being activated. When it gets too hot, it's pain receptors that are activated, not the hot receptors. So whenever I go outside of the range on an awful lot of things, awful lot of our receptors, we have a window where they work. If I'm outside that window, many times it's going to stimulate these nociceptors. And nociceptors exist in different places. I'll give you an example of one that we're going to talk about in special senses, but it exists here in the chemoreceptors. How many people here like peppers? Hot things. Okay? So there is a flavor profile for each pepper. But what most people like about peppers is it stimulates this. So you're kind of a little masochist. Or a sadist, I guess. Masochist, what? Inflict pain on other people. Sadists want pain inflicted on them.
Masochist is on yourself.
Masochist is on yourself.
I think so.
Okay. So, whichever one. It means that you like pain. Because that's really what's being triggered there. Because they don't really have a flavor profile. It's what you mix with them. Okay? So, and I think it's the Scoville chart that is the chart that basically lists the hotness of the thing. And I think the ghost pepper is the hottest.
Yeah.
So, anybody know, by the way, I'll get your question in just a second, what you're supposed to drink, just since we're on the topic? Milk. If you drink water, it dilutes it, but it puts it all the way back in the thing. There's molecules in milk that actually will decrease the activity of pepper.
Okay, so for the nociceptors, like if you're having too much pressure and it becomes painful, like
Yeah.
with the mechanoreceptor, would the actual mechanoreceptor turn off and then the nociceptor turns on, or are they all stimulated at once?
Now they're all stimulated at once, but they will have a priority on how they're processed as they start moving along. So the pain takes a higher priority. And when we get into pain, which I should be able to have some time in this chapter to get into pain, you have ways of decreasing what's actually getting up to. So again, sensation, perception. If it doesn't come up here, you're not feeling pain. So I can give you medications that basically block this area up here. I can give medications that block the transmission up. I can do things that cause a distraction. For those of you, again, who work in the hospital, you might have a patient that's supposed to be getting their 2 milligrams of morphine every 4 hours, and they've been having pain, scale of 1 to 10, it's about 5. Family comes in, keeps them entertained for about 4 hours, they're watching TV, they're laughing, and you don't really experience a lot of pain. Why? Because you have that process that's coming from the central nervous system, and it's dampening down what actually makes its way up. It's called the gatekeeper theory. So, and again, we should be able to spend time talking about it. Now, we can take all those exact same receptors, and instead of basing it off of what turns them on, we're going to base it off of their location. Now, we have basically 3 primary locations. Okay? We have exteroceptors, those that tend to be more towards the superficial component of the body. In other words, I can feel hot, cold, pain. I can have interoceptors. These tend to be on the inside of our body. These are also things that you, for all intents and purposes, are not aware of. Now, you can have pain on the inside of your body, and that would be triggered by one of these, but normal stuff. Your blood vessel diameter. So as I stand up here, to be able to stand upright, my blood pressure is going to change. Okay? If my blood pressure went too low, I'd pass out, and hopefully somebody would know how to take care of me, which is the reason why I teach, just so if anything happens, you people know how to take care of me. These are things that are going to change. We are not aware of them. They maintain the normal homeostasis inside the body, but they are inside the body. Sometimes they're referred to as the visceral receptors. Visceral meaning kind of a gut reaction, okay, the inside. And then the last one are proprioceptors. Proprioceptors, again, these are the things that are going to take information about the position of our joints, our muscles, our tendons, and send them to the cerebellum. Okay? So, location, towards the surface of the body, inside the body, joints, muscles, and tendons. Now, I can also base it off of complexity. So, and again, let me just make a point here, because I'm not going to spend that much time with it, but all these I would be able to classify as either exteroceptors, the interoceptors, or the proprioceptors. Didn't change what they were. I'm just describing them from a different component. Here we're going to talk about the complexity of them. Okay? Is this something that was simple, which most of them are, almost all of them, are special senses. Okay? And our special senses, we always talk about there being 5. One of them is going to be locked in here, so in peripheral nervous system. So when we talk about our special senses, we're talking about sight, sound, taste, and smell. Okay? This chapter is touch, feeling. And it's not considered a special sense. All right? So our special senses generally encompass a more complex group of receptors. It's not just one of them. But the rest of them, we're going to divide into free and encapsulated. Sometimes instead of free, we use the term unencapsulated. Okay? Now, the difference between these two, one wears a hat, the other one doesn't wear a hat. And what I mean by that is that the free nerve endings, basically, they just have a receptor, so that the stimulus is specifically touching the receptor itself. When we talk about things that are encapsulated, it wears a hat. There's a connective tissue that actually surrounds the receptor. So the stimulus is not coming in contact with the receptor. Stimulus is coming in contact with the thing that surrounds it. So as you push down on this, it actually then causes that deformation that we talked about from a mechanoreceptor standpoint. And that's what's activating the nerve and sending it along, providing that we've reached our action potential as opposed to a graded potential. So when we look at the Meissners, the Pacinians, the Ruffini, they're going to change those, by the way. So when you look at them here, we've got tactile, lamellar, bulbous. So if you notice, you've got Meissner's, Pacinian, and the Ruffinis that are in there. I'm not going to ask those specifically. You're not going to have to put these in a box. What you should be able to tell me is when we talk about complexity, is I'm looking for simple. And under simple, does it wear a hat? In other words, if this is my hand is the receptor, does the stimulus come in direct contact with my hand? As opposed to this wearing a big giant mitten or a big giant boxing glove. And it would be pushing down on the boxing glove that then causes the deformation here. That would be the example of an encapsulator. So simple, hat, no hat. Complex, again, our special senses, sight, sound. Now, we have different levels. So it's going to look like this. This is the receptor level, which is what we're going to spend time talking about. This is the circuit level. Why am I not going to spend a lot of time talking about the circuit level? Because we already went over it. This is the whole spinal cord. First order, second order, third order, spinothalamic, spinocerebellar, dorsal columns, medial lemniscal, and then we'll talk about the perceptual level up here. Okay? So, receptor level, again, so what's going to happen at the receptor? We're going to talk about that specificity. Okay? There has to be the correct stimulus for that receptor. If it's not there, you're not going to have a response. Now, we also have what's referred to as a receptive field. In other words, if my job as, let's say that I'm an alarm system in a house, and my job is to look at this square right here, and that's all I have to monitor. If there's a bad guy in that square, there's a bad guy in that square, hey, it's not my business. This is my business. Okay? So you can have the different receptive fields that are present, and you're only responsible for the one that you have. Now, one of the things that this we used to do this in lab a lot, and we had a little bit more time for it. It's not that exciting of an experiment, but what we would do, if you notice, is I've got this compass that's up here, so I've got pinpricks on both ends of the compass. And I've got 3 receptive fields here, correct? Are the 3 different colors? So if I'm poking one and poking another, I hopefully would feel how many pinpricks? 2. Guess how many I feel here? 1. Because all 3 report to the same boss. And this boss is only going to send up 1 impulse. They could have 1 in all 3. But because of its second order neuron, it's going to say, I only feel 1. I'll get your question in just a second. Over here, where I've got a lot of different ones, if if I feel one here and I feel one there, they report to different bosses. There's more second order neurons in this one. Therefore, here I would feel 2. So areas that we tend to have the need for a much closer monitoring, tips of our fingers, face, tongue, we tend to have this. Whereas things like our back, our neck, chest, we tend to have this. There doesn't need to be as much of a one-to-one relationship in those areas as we have on our tongue, our hands, our face.
Yeah.
Okay. Now, this next one is a little bit confusing for students simply because of the terms that are used. So the first thing that's going to happen is we're going to transduce the stimulus. Transduction simply means that I'm changing something. So for those of you who had me for A&P1, we talked about this impulse that was going to come down the axon into the axon terminal, and we had, let's call it an effector on this side. So this is electrical right here. So I'm going to have something happen so that the impulse comes over here. Does it just go super fast and jump over the synaptic cleft? No. I go from an electrical impulse to what? A chemical, and then back generally to an electrical, depending on what the effector is on that side of the postsynaptic structure. This is called transduction, going from electrical to chemical. Now, the transduction can also be, I have a chemical that's bound here. It could be a chemoreceptor, a tastant, or an odorant that binds, causes depolarization, and then I have a neurotransmitter that's released. That is also a transduction. I'm simply taking an impulse and I'm changing it to another type of impulse. Now, we have these things called receptor and generator potentials. Okay? So, if I have a first order neuron, and that's where my receptor is, if the receptor binds a stimulus, and it's enough of the stimulus that will cause an action potential, and that will move along the first order neuron. And this is referred to as a generator potential. If I have a cell that is not the first order neuron, but it's attached to it, or in close proximity, if I have a stimulus that binds there, and it causes enough of a response, I have a receptor potential. If that receptor potential is strong enough, it will cause a neurotransmitter to be released, which causes a generator potential in the first order neuron. Now, to make this very simple, if the stimulus binds to the first order neuron, it's a generator potential. If it binds to another structure that activates the first order neuron, then I have a receptor potential that causes a generator potential. Look at the cell that receives the stimulus. If it's a first order neuron, you will have a generator potential automatically. Sometimes we call those that the receptor potential and the generator potential are equal. If I have a cell that receives the stimulus that then activates the generator potential, then I have a separate receptor potential and a generator potential. I'll give you an example. Taste. Okay, we have 5 tastings. Sweet, sour, bitter, salty, and umami. If one binds to a gustatory cell, okay? If it's strong enough, it causes depolarization, a neurotransmitter would be released, and that activates the first order neuron. Facial nerve, glossopharyngeal nerve, or the vagus nerve. Those are the nerves that our tastings are traveling on. That makes some sense, a little bit easier. Yes, ma'am.
Would a different neurotransmitter be released depending on the taste? Or would it be a different cell receptor that?
There are different, it's essentially the same neurotransmitter, but it causes a different type of action. And not, let me rephrase that because that's not the correct statement. It causes a different frequency of action potentially. But each gustatory cell responds to a different taste then. So, but that's special senses. So when we get to special senses, we'll get a little bit more into the weeds with that. Okay? Now, our receptors also have the ability of saying, you know what, I'm getting a little tired of constantly being activated. So they will adapt. There are 2 ways of adapting, tonic and phasic. Phasic adapts very quickly. Taste is a phasic adaptation. So you have a nice dinner, some steak, baked potato, maybe a glass of wine, and then dessert comes, and it's cheesecake. You take a bite of the cheesecake and you're like, oh, this is really good cheesecake. But I guarantee you that the 5th, 6th, 7th bite of that cheesecake, it's still good. It's not like suddenly you take a bite and you go, this tastes like dog crap. But it doesn't have that same wow factor that the first or second bite did. Why? Because your taste buds adapt. Smell adapts. Anybody here ever been in a cadaver lab? So when you go into a cadaver lab the very first time, you're like, oh Lord, I'm not going to be able to spend a whole entire term in this lab. But by the end of the class period, you realize it's not as bad. You still have that smell, and it's not, it's the preservatives is what, if you haven't ever been in one, that's what the smell comes from, is the preservatives of the cadavers themselves. If you've ever sat next to somebody who had gym before their class, and instead of taking a shower, they decide that they're going to just kind of douse their body with perfume or with an aftershave. And you're sitting next to them and you're just thinking, holy moly, this is not going to be fun. So obviously as the class goes on, the chemicals from their, whatever they put on their body will eventually start to dissipate as well. But your nose will actually start to adapt. Okay? Now, tonic either adapts slowly or they don't adapt at all. Okay? Pain is an example of something that adapts generally not at all. Now, I'm not talking about chronic pain. Chronic pain is a whole different beast because adaptations can actually occur at the cortex as opposed to down at the receptor level. Okay? But acute pain, we don't really want it to adapt. Why?
It's useful.
Why is it useful?
So you can pull your hand out of the fire.
You can pull your hand out of the fire. It's a protective mechanism. It hurts when I do this. Don't do that. Okay? So unless you have this overwhelming sympathetic discharge, it's actually going to be blocking it, which is the reason why you can get people that will play the end of a game on a broken ankle. You know, people that can do amazing things when they're in such excruciating pain. So you really don't want it to adapt. Does anybody want to take a stab at probably the second one that you don't want to adapt? Not hearing. Balance. Our vestibular system. I do not want to lift my leg up, put my head back, close my eyes, and then have the body go, okay, we've adapted now. Because then my body doesn't know I'm doing this. And I'm going to probably fall. So our vestibular system is another one that we generally do not want to adapt to any great degree. Yes, ma'am.
So you said that tonic was the non-adapting?
Yeah. Basic is faster. So again, circuit level we talked about, it's ascending, reflexes, thalamus, cerebellum, cortex. So reflex is going to be something that we spent some time with at the end of this chapter because these, again, are spinal cord mediated responses. So again, grabbing something hot, I'm going to cause my hand to pull back. Okay? So I have flexion. And we'll talk about the different types of reflexes. But that does not involve doesn't involve the upper central nervous system. It involves the spinal cord. That's why it's referred to as the spinal cord reflex. Okay? But they're also going to go to the thalamus, cerebellum, and again, if it goes to the thalamus, it's going to go to the cortex. Okay? And that's our specific, non-specific spinocerebellar, dorsal column, medial lemniscal, spinothalamic, spinocerebellar. Now the last one is the perceptual level. In other words, what happens up here in the noggin once it gets processed up there? So it's obviously going to go to our somatosensory cortex, or one of the cortex, the sensory cortex, off to an association area if it has one, and then the multimodal association area where we're going to put everything together. So here we have projection. In other words, I know where it's at. Pain's coming from here. Okay? We have the overall awareness that something is there. Now we know what it is. Because again, that's what's going to occur in this cortex, is perception. So I step on a rock, I feel pain in my foot. That's a sensation, it's an awareness. But knowing what it is, oh, I think I just stepped on a rock. That's perception. Okay? We have magnitude. So you're making soup, you're going to put some salt in, taste a little bit of salt. I can put in much more salt, and now it tastes like there's much more salt. The amount of action potentials that arrive on that particular neuron is going to tell me how much is there. Is the music loud? Is that a deep blue or a light blue? Is that an overwhelming sense of peppermint or just a faint sense of peppermint? So that's what magnitude means. How big is that stimulus? How do we perceive that? And again, spatial kind of goes up with projection. Now there's going to be a couple, in other words, you're able to identify its location. There's a couple other ones your book goes into that are a little bit more difficult, which are things like the subcategories. So taste. I'm able to tell the difference between sweet, salty, sour, bitter, and umami. Okay? Facial. I can put everything together. I'm not looking at just your nose. I can look at your nose, your eyes, your mouth, your cheeks, and put that together as a face. So there's a variety of things that are going to occur once you get up into the perceptual level in the cortex. All right? The big ones really are, you know it's there. That's the first thing. You have perception. You're able to tell the magnitude, and you're able to tell the location. Those are probably the three biggest things that are going to occur at the perceptual level. Okay. I think cover just this last part of the anatomy of a nerve, and then I think we'll go ahead and call it a day. So this is one of those things that we've kind of a little bit lied to you about, because when we talk about neurons, we sometimes use the term nerve, and that's the incorrect term. A nerve is actually made up of a bunch of axons from neurons. So its structure is very, very similar to muscle. So when I start going over this, you're going to see that we use a lot of the same processes. So here I have my axon, right up here. And remember that it has that myelin sheath wrapped around it from what type of cell? The Schwann cell. What's the name of the cell from the central nervous system that makes the myelin sheath? The what? The oligodendrocytes. Now, I'm going to take a fairly delicate connective tissue, and I'm going to wrap it around that axon that's surrounded by the myelin sheath, and it's referred to as the endoneurium. And then I'm going to take a bunch of these, and I'm going to wrap them up into a little bit stronger connective tissue. The connective tissue is referred to as the perineurium, and that's going to make up a fascicle. So again, hopefully this is starting to sound somewhat familiar with muscle. We had a muscle cell, we took the muscle cells, we wrapped them up, we made a fascicle, we took the fascicles, we wrapped them up, we made the muscle. So here, I'm going to take all my fascicles, I'm going to plug in some blood vessels right in the middle of them so that we can nourish them. I'm going to wrap them into an even stronger connective tissue, and I'm going to refer to it as the epineurium. So the epineurium surrounds the nerve. The nerve is made up of a variety of different axons, and they are packaged in such a way that these are probably going to be going in the same general area, as opposed to, I mean, when I say the general area, I mean the general area, if we're talking about a muscle, it's going to go to the same general motor unit. Okay, so remember we had an alpha motor neuron that goes to skeletal muscle. So these are probably all going to the same type of motor unit. The nerve itself, more than likely, is probably going to the same muscle, if that makes sense. Okay? So one of the things, again, that we have a tendency to do is we talk about neurons as being nerves. And really a nerve is a bunch of them together. The axons of those nerves. The cell bodies are not in here. Okay? Cell bodies are farther out. Now, one of the things that we notice about nerves is that, again, they can have a motor component, only motor. They can have a sensory component, only sensory, or they can do both. That's why you learned that little mnemonic yesterday with your cranial nerves. Some say marry money, but my brother says it's bad business to marry money. So cranial nerves can be both motor, sensory, or mixed. Spinal nerves are all mixed. It's like a two-lane highway. They have information that goes out, information that comes in. Any questions? I'm going to say regeneration until Monday. All right, so again, please, before you've got tomorrow, you've got Saturday. Most people don't really start to celebrate the 4th of July, but make sure you do not get behind. Or I guarantee you next week is not going to be fun for you. You're going to be playing catch-up. Okay, have a safe holiday, and not Monday. I'm already thinking that Monday's going to be the 4th of July.